All right, well, let's get started. Good afternoon, everyone. My name is Christina Clayton, and I'm very grateful to be with you all today. I'm a clinical social worker and the program manager of the Northwest Mental Health Technology Transfer Center. I would really like to welcome everyone to today's webinar on behalf of the Northwest MHTTC and our partner, the Behavioral Health Institute, and their Training, Workforce, and Policy Innovation Center. We really appreciate that the capacity to provide effective telehealth treatment has become an urgent issue in the context of COVID-19. And we're really excited that this is the fifth webinar in our 8-part series that aims to support community-based behavioral health providers in Washington in their implementation of telehealth services. We will share how to access prior sessions via the chat so you can view recordings, see the slides and Q&As, as well as resources. We've structured these sessions so that ample time is dedicated to Q&A and discussion. But first, a little introduction to the Northwest MHTTC. Next slide, please. So the MHTTC network is a nationwide network that is supported by the Substance Abuse and Mental Health Services Administration, otherwise known as SAMHSA, with the purpose of disseminating and implementing evidence-based practices for mental health disorders into the behavioral health workforce. Next slide. Our center, Region 10, is, based at the University of Washington in the Department of Psychiatry and Behavioral Sciences. We provide training and technical assistance, otherwise known as TA, and evidence-based practices to Region 10, which includes Alaska, Idaho, Oregon, and Washington. And broadly, our goals at the Northwest MHTTC are to ensure the availability and delivery of free, publicly available training, heighten awareness, knowledge, and skills in the workforce, especially around mental health treatment, accelerate adoption and implementation of mental health-related evidence-based practices and other practices across Region 10, as well as fostering alliances among culturally diverse providers, policymakers, families, and clients. Next, we'd like to support first-person language. It is our intention to always be mindful of using language that promotes recovery and culturally appropriate terminology. We encourage everyone to use and champion person-first language, which emphasizes the individual, not a condition or disability. This way we can demonstrate respect and dignity and worth for people. Next slide. We have a few logistics to review in communicating during the session. So first, we do have the chat box, which is only visible to our support team. If you have a technical issue, please share this in the chat box and someone will get back to you. So to you from our training team or from you will only be visible to the hosts or panelists. It's not for content related questions. So you'll see the next slide about how to do that. So there's two options during this session. And as it is a large group, we have folks muted by default. So during the actual discussion part, we won't interrupt for questions, but the goal is for us to hear your questions and challenges and help you to address them. So there's two ways you can do that. One is you can type a question into the Q&A window. If it's a short thing that someone can answer written, they might do that, or they might save it for the discussion part. Number two, you could raise your hand and you can see where to do that on your screen, and you'll be called on and unmuted when we get to that part of the discussion. If you accidentally raise your hand, you can certainly lower it if you need to. The didactic session, as we said, it is very important, and we want to make sure the presenter gets through that, so we won't interrupt at that time. But we will be monitoring the Q&A box and facilitating as many questions as possible. We will also be doing a summary Q&A sheet. So if we don't get to your question or can't do a short written answer, we'll be posting those to our website. Okay, next slide. After today's session and near the end, we will be posting in the chat box, but our goal is to rapidly incorporate your feedback into subsequent sessions in this series. Another opportunity for you to do that is to respond to a confidential survey that we'll share both via the chat box and an email. We're required by our funder, SAMHSA, to do this survey, and your participation does help support future trainings and help us demonstrate what we did and how well was it received. We are not able to provide certificates or CEUs for this series, but as I mentioned, slides and resources, as well as the recording, will be posted after the session. All right, now to some introductions about our presenter and panel. Today, we're very grateful to have Dr. Jennifer Erickson, and is Assistant Professor in the University of Washington Department of Psychiatry and Behavioral Sciences. She works at the UW Medical Center, 3 outpatient clinics, and 1 telepsychiatry clinic that uses the collaborative care model. She teaches telepsychiatry curriculum for both the full-time integrated care fellowship and in the community-based integrated care fellowship. She also leads the quarterly in-person sessions for the community-based fellowship and is a member of the UW Medicine Psychiatry Consultation and Telepsychiatry program. Dr. Erickson's interests include neuropsychiatry, medical ethics, population health, and medical education. Our panel is the same wonderful group of experts from earlier sessions, so we're happy to have them here again as well today. At this time, I'll turn it over to Melody from the BHI.
Thanks, Christina. Hi, everybody. My name is Melody McKee. I'm the Program Director for the BHI's Training, Workforce, and Policy Innovation Center. Appreciate being here today with Northwest MHTTC. We've been delighted with the series so far and can't say enough about their generous partnership here in this effort. You'll see a slide at the end of the presentation today that gives the telehealth rapid resource website that you can go to for more information about our effort and providing telehealth training resources across Washington state to our wonderful behavioral health providers. So you've heard some about the presenter, the panelists, and Northwest MHTTC, and we'd love to hear a little bit about who you all are and where you're coming from and what type of provider you're representing here today. So you're seeing a poll pop up on your screen, and if everybody could answer the poll for us, it gives us a good idea of the representation in the group today. Looking at the poll, so the choices in the poll are prescribing provider, nurse or other medical worker, behavioral health clinician, therapist, case manager, outreach worker, administrator, tribal behavioral health or tribal health organization, education, school or school-based organization, or clinical supervisor. It looks like we have a good group, solid group of behavioral health clinician therapists. Looks like 1 nurse or other medical worker, 1 case manager, a handful of administrators, and excited to see some tribal behavioral health representation today. That's great. Some clinical supervisors. So good mix of individuals on the call today. I appreciate you all being here. So now, in order to get rid of that window on your screen, you do have to click on it yourself, just so you know. And I'm going to turn the presentation over to Dr. Erickson.
I'm getting rid of the poll myself. Give me 1 second, guys. There we go. Okay, so hi, greetings. I'm Dr. Erickson, like they were saying. We're going to talk about clinical workflows today. The alternative title of this presentation was How I Bumbled Through My First Clinical Workflow Experience in Creating My Teleclinic. Don't worry, everyone does it. It's not just you guys as you're learning to do tele on the fly. I definitely had this experience, and this was 4 years ago, actually, when I started my first job. So taking a breath, acknowledging that we're doing good enough. Clinical workflows are really, really exciting. You guys, I guess over the last couple of weeks, have heard little bits and pieces about this needs to happen in tele, that needs to happen in your clinic. Clinical workflows are where you actually got to start dreaming what your clinic's going to look like, how it's going to function. And so consider this an introduction to guided dreaming, so to speak. So we have some objectives. We'll list 4 components of a telemedicine clinic that should have a workflow. This is some disclaimers, just remembering this is not legal advice. Always consult your legal counsel. And this presentation is up to date as of 4:30. So why have a workflow? Well, in general, thinking about workflows, clinics in general run on workflows. If you think about it, how someone comes into the clinic, how they check in, how they know what paperwork is the correct paperwork to give someone, how they know to get back to a clinic office, how they know who needs to go into that room and when that patient leaves, that's all a clinical workflow. And when you formalize it, it allows people to go through A to B seamlessly without even knowing it's there. And that's kind of some of the purposes of workflow. It does prevent backups and confusion. You don't want someone coming in and thinking they're going to see their doctor when in reality they end up in the lab or getting an x-ray for some reason. That can be confusing to our patients. It also is very, very confusing to our providers. And there's enough confusion going on at the moment. It manages expectations as well. So it tells providers what they need to be doing, where they need to go. It also tells patients how this is going to flow. And it also can guide us for rare or emergency events. When you have a workflow and a workflow plan, you don't have to think about it, but sometimes there are things that go outside the norm, and how to actually work up, say, an emergency that happens in the middle of the clinic. It's really important to have a thought out workflow and not have to figure that out on the fly. So what are workflows like? I happen to particularly like similes and metaphors. You can think of a workflow being like a recipe. Like a lot of people right now, although this was before, I like cooking, I like baking. If I can write out a recipe and give it to someone and they can make exactly what I'm making, that is an effective recipe, much like you want a workflow. You're going to potentially spread this across multiple clinics. You want to create that recipe so they know what they're doing. It could also be a playbook if you're very into sports. It's almost a syllabus as well. So workflows keep things consistent internally day to day in the clinic, but also potentially across multiple sites. What could this look like? Now, I know this is a very, very overwhelming screen with lots of little details on it. Do not feel like you have to read all of the details and absorb this all at once. We're going to break this apart. This is one of the simpler workflows that we're going to use to guide through how to think about the different places in a workflow, or different places as a patient passes through a workflow. This is an inpatient workflow. At the end of this, we'll talk about how we're doing into home, tele, and outpatient workflow stuff. But this is kind of to give you an idea. It's a swim lane example of a workflow, but you'll see at the top it's broken into before, during, and after. So pausing before we get too stuck on this slide. This could also be an example of another workflow, again, just to give you a feel for it. But they all have kind of a look to them. What is happening, who needs, what needs to happen, and who needs to do it are all part of those workflows. This image down at the bottom is a fancy, there's a particular type of origami that exists. And all of that huge swan is built by those little tiny papers that you see on the left there. And that's a bit like what you're doing when you look at one of those big workflows. You're creating this huge thing that seems really complicated, but actually the components of it are very, very easy, and you're just putting them into the correct places. So speaking of what and putting things in the correct places, we're going to take a moment to talk about tele. So this is our kind of where and what of those questions. Telemedicine is different than in-person, right? Yes, not news. Telemedicine is also very similar and almost the same as in-person, not news. So you're somewhat set up that both of these things, setting up a telemedicine clinic versus not setting up a telemedicine clinic versus an in-person clinic, they're similar but different. And you have to account for both the fact that they're similar and both the fact that they're different at the same time. It's very much a dialectic. I'm a psychiatrist, I have to drop that conversation in, but you have to hold both of those things in your mind as you're setting up a workflow. And holding on to that, as I like to say, it's both yes and no, it's part of life, but it's important to hold on to those things as part of your workflow. So briefly reviewing, what are the similarities between tele and in-person? Your providers, whoever they are using clinical skill sets that are effectively the same as in-person. When I see a patient, I am doing a psychiatric diagnostic interview. I am still building a relationship with the patient. There's just technology in the way, which we'll get to the differences. Still doing a clinical assessment. Usually there's still some chart review involved. There's some level of documentation. And you also probably need to talk about staff, whoever's involved in that, with managing steps. So very similar to walking into a clinic. How is it different? The provider doesn't actually walk into the clinic, right? You have to keep in mind that there are 2 computers involved in this, at least. So if I am speaking to a patient via tele, I have to have a computer that has appropriate access. The patient, wherever they're sitting, also has to have a computer that's appropriate access. That results in 2 clinical locations. So you have to account for my clinical space, whatever's behind me, whatever's in the room needs to potentially be accounted for, And if the patient's in a clinic, that clinic space needs to be set up in a HIPAA compliant way. If they're at home, sometimes you have to have protocols in place to encourage the patient to set up a space for themselves that might work. I like to remind people that as opposed to walking to the clinic, if it isn't in the electronic health record or visible easily, it doesn't exist. So if I were to walk into an in-person clinic and have a question for someone or try to find, say, a piece of paper that someone dropped off, if it's not scanned, I don't have access to it via tele. And then the last thing I'd like to point out, especially if you're working with providers who potentially are working in new EHRs, you can't assume that just because someone uses Epic or another EHR, they're proficient in your version of Epic. I don't know if people realize that, but Epic does get specialty features turned on and off depending on location. And you can't assume that that person has access. Same thing with patients. When someone comes into a physical clinic location, typically all of that stuff has been checked off. Someone has access, someone has been trained. But something to think about as you're setting up your workflows for people. So who should be on your team as you're thinking about creating a workflow or you're creating this clinic? I like to think of this as being a multidisciplinary team. You probably want sort of, one of every thing you're working with. So potentially anyone who's going to have contact with the patient, anyone who's going to have contact with the clinic. You may want to even think of tech people being involved because technology is such a thing, especially when you're doing tele. And you may also want to let your billers know or your legal team. So having people look and vet and have to say in creating a workflow also is really, really important. So workflows, getting started, right? You're all ready to go. You've thought, I've got my team together. I get it. Tele is different and the same. We can hold on to those things. But before we go marching across the line and creating all this stuff, you need to make sure you've dotted some I's and crossed some T's. Number one, like I said, you wanted that big team. You have to make sure that people are potentially trained. So who is going to be running the equipment? Who is going to need to turn on the screen? Do your providers need other EHR access? Do patients need potentially a little training blurb? Are there issues with credentialing? If you're bringing a new provider to work in your clinic site, do they need new credentials? And then as you're starting to think of the starting process, I like to think one hand washes the other. Staff will turn over. So as you're creating your training process, documenting that and thinking, okay, this is what staff turnover is going to look like, and this is how we bring someone on board. All right, so going back to this messy workflow, we're going to focus on this part of it. As I said, getting back down to that little triangle to create that really beautiful goose. We're going to focus on before the appointment. So what's happening before the appointment? So prior to starting, prior to getting a patient in, we're going to take a collective breath. And I always remind people to do that. We start by looking at both the clinic sites, right? So there have to be 2 clinic spaces. And you want wherever your provider is sitting to be potentially set up, and we'll talk about some tips for that. And if you're calling into a clinic, which most of you are not, you need to think of that clinic space. But if you're calling into home, having some things written out for patients about where they could sit, some expectations, such as maybe they should not be actively driving at the time of their appointment. What you may ask is important to think about. And potentially document. Making sure that people are using HIPAA compliant software. I'm sure people have seen in the news about this, but I believe everyone is using Zoom that's connected to this or something similar, but always check and make sure the software is HIPAA compliant and that your provider has access to it and your patient. Make sure there are appropriate scheduling templates set up, right? So this is potentially another clinic. All clinics have some sort of schedule. Taking a moment and actually finding out if there's a schedule. So I will point out things that happened when I was setting up my teleclinics. I like to describe this as error number 50. I did not have a template for the first week and a half that I was doing tele, and it took us a while to figure that out. Error number 5 was that going back to the clinical space, we discovered that there wasn't a camera at our originating site. So these things come up. It's better to catch them before you have a patient come in. As I said, when you're setting up your big team, having legal approver consent, legal look at any consents or disclosures you're doing. I believe we've talked about some of that in a vague term, but making sure they're vetting any dot phrases or things you're using, such as, you know, saying something as a tele-appointment, or documenting appropriately, dropping bills appropriately, disclosures about what's going on in the appointment. Make sure legal has looked at that. And then of course, make sure billing's aware that new bills are coming at them and they need to be potentially aware, and not just that, but what they should potentially look for in those bills. Okay, so what else do we want to do? So before setting up to an appointment, just thinking about, in general, like any other clinic, how are referrals going to come to you? Are they going to be screened? And if so, who screens them? Are they going to end up in a big bucket someplace? Or are they going to be triaged off? Who decides when an appointment is set? Is that going to be the front desk? Is that going to be the provider? Is that going to be some other person? Do they have access to the EHR to actually do that? And then how is it communicated that there's going to be an appointment? Obviously, if you're setting up most things, you would have an outpatient schedule and there would be that, but say you're doing something more on the fly, making sure it's communicated or have a standard way to communicate is important. Are consents required? You know, for the most part, it varies state by state, depending on whether something's written or verbal. I believe people have gone over that here. Washington State's verbal, not written, but always checking on that because that is such a moving target right now in the time of COVID. Okay, so that's all of our prior to the appointment. So we've got someone scheduled because we were really, really on the ball and we did stuff. We got them plugged in. What about during the appointment? What does that look like? So things to think about when someone physically comes in for an appointment. How is the patient checked in? Here at UW, other places, when there are teleappointments, there's actually someone who goes through at the beginning of the day and checks in all of the patients. And then if someone does not show up, they're unchecked out. But without that person, a patient would never be checked in. And depending on the EHR you're using, you may not have access to certain features in it unless someone's physically checked in. Obviously, if they're physically coming to a clinic, it's a little different, but especially with telehome, things have changed a bit. How does the provider know that someone is ready to see them or that they have someone to see them? Especially, you know, going back to the whole checked in, if someone's already checked in, it's hard to know if someone's there. Do you have a protocol or is there a workflow around someone notifying you that they're checked in? Sometimes Zoom will notify you, but knowing that and having that explicitly written out for providers. If the patient needs equipment, how do they get equipment? Are they screened before? How do they get to the equipment if they need to get to the equipment? Who turns on the equipment on both sides, right? And then what is required of the two rooms? So we're going to take a moment and actually talk about rooms. I know you guys have seen this before, but rooms in general, it's important, especially for your providers to model this, but also you can help coach patients if you need to. The two on the left are obviously well-lit, front-facing images of people who are theoretically doing Zoom well. One is of me. One is actually of Kara's daughter. And then you can see the variations and problems that happen. So sometimes providers or patients will look off to the side. It's helpful when they look straight forward. And obviously you want to monitor lighting, but it's not just that. You want to make sure, especially if providers are running tele out of their home or patients are potentially seeing providers out of the home, that we put in an effort to introduce anyone who's either in the room or entering the room. So that's why I encourage patients to have a private place. This is their medical appointment. But also providers should ideally have a door that they can close and label. This is one of my handwritten signs when I have to do tele from home. There's a lot of interesting memes online of, you know, moms writing huge lists of what to do if there's an emergency. But again, labeling it. If anyone's physically in the room besides you need to make sure it's documented. If anyone's on the patient side, they also need to be documented. No one should be allowed to enter the room unless there's an emergency. And again, make sure you're using HIPAA compliant software. And then if another thought about rooms, just as a reminder, I know you went over this, rooms, especially as home-to-home telemedicine continues, just a reminder, mind your backgrounds. So as you can see up in the corner, there happens to be someone video bombing, or Erin again. And then, avoid screen crashers. That is one of my 2 cats. They are not allowed in the room. I lock the door. They actually have 2 doors between me and them. I have seen so many cats on televideos with patients. I actually had a patient whose cat attacked the camera at one point. So just be aware. They're there. Mind your critters. You can encourage patients to mind their critters too. But just remember, professional rooms. Okay, what about the encounter? Well, typically a provider, whoever's running, who's ever seen the patient is going to run the encounter. They should be aware as part of the workflow that they need to introduce themselves to the patient. Unlike when someone comes into the clinic, if you are meeting someone via tele for the first time, you probably need to take the time to show them your badge, fully state your name, and then ask them their name and get their date of birth to confirm identity as best you can. You introduce everyone else who's in the room, and then you're going to verbally consent the patient for a telemedicine appointment, and just routinely verbally consent people for a telemedicine appointment every time you do it. Believe it or not, at that point, you would run a normal telehealth appointment. It's almost, like I said, similar but different. As a psychiatrist, I can do a psychiatric diagnostic interview after I've done consent and move forward and make recommendations and do all that. So what happens after your appointment? Okay, how does the encounter end, right? So we've now completed an entire diagnostic interview or an entire medical appointment. How does it end? Who helps the patient do the next step? Is this you both log off? Does the patient need to follow up someplace? If they need labs, do they know where to go? And who's going to contact them for the labs? Who turns over the room? So if you're doing tele and you have someone who's logging on to the appointment and running the appointment for you, are they going to switch the tele appointments? Are you switching the tele appointments? So having that written out can be helpful. If we ever get back to doing tele into other clinics, knowing who's going to come in and make sure there's no PHI lying around, wipe things down may be important as well. And then, of course, remembering where the recommendation is being recorded. I've worked in clinics where I have written directly into their EHR. I've worked in clinics that I've written into a different EHR and someone had to copy and paste the note over. But setting that up and knowing what those steps are and documenting so people can follow it coherently. Speaking of documentation, knowing where the note lives. Is it in their EHR? Is it in your EHR? Where does it go? Making sure you know specifically what it contains. So again, others have probably spoken about this, but if you are doing a standard clinical assessment, like again, I go back to psychiatric diagnostic interviews, I have to have all of the components of a psychiatric diagnostic interview, and I need to make sure it's labeled appropriately tele with my consents with all of the stuff on top. Knowing that and making sure providers and whoever's writing those notes have that written down. Who needs to document, right? When we're doing tele into home, often it's directly the provider. There's a little nuance if you're doing tele into another clinic that I will skip for right now. But knowing that and documenting that's important. All right, so talking briefly about billing. Billing typically tends to be very, very similar to what we do, right? Similar but different, except you add a GT modifier to the end billing code. There can be additional billing code depending on the location site if someone is in another clinic or in another building. If they're at home, ignore line 2. You have thought of everything, right? So now we're going to do some testing, right? I perfectly do everything perfect the exact same way, the exact same time, the first time I do it, right? Everyone does? Well, I don't, and I suspect you don't. But before you have your first full clinic day, maybe we take a moment and have people beta test their roles. Make sure someone can actually log on. Make sure someone can check things. If you're doing, say, PHQ-9s, make sure that the provider can actually see the PHQ-9 or even test how that's going to happen. If you're having a patient input data, figuring out, is that visible? What should be tested? So thinking about, do we need to turn on both the cameras? Do we need to test the EHR? Believe it or not, the more things you test, probably the better. But also know that you will not be able to test everything. You will not remember to do everything, and things happen. So that's why as you're testing, you're going to create a game plan for retesting, right? I can tell you that, you know, there are things that surprised me the first time I did tele, and they were not surprising the 5th time I did tele because we'd addressed them. But knowing that this is a living, breathing process. So run with it. Speaking of one more things, I know that Brad spoke with you last week about events. I want to go over just some things to think about as you're creating your tele document. I actually was on a call with people this morning where someone's power went out and they had to figure out how to call in just by phone, and we had to create a game plan for that on the fly. So that will now be part of my workflow. But other things to think about. What happens when the computer won't work or stops working, right? Because the power went out. What happens if the patient has a medical emergency when they're on the call for you? Everyone gets really, really stuck in mental health about, well, what about a suicidal patient? I always pause and go, what happens when the patient falls off their chair and hits their head? Or conversely, a cat attacks them, like happened recently. What happens if a staff member is sick? So I like to call this my tele startup clinic error 5000. When I was originally doing tele, it was into another clinic location, and we actually had a staff member, the one person who knew how to turn on the camera and work with the tele equipment, call in sick, and I didn't know that, and the patient panel didn't know that, and we finally figured that out an hour-ish before my first patient came in, and we had no one on site to potentially see patients, so we ended up having to cancel my entire afternoon and reschedule everyone. That happened once, and then we had a plan for it. Unfortunate, and everyone was stable. It worked out in the end, but knowing some of those things. What happens if a patient walks out of the room? What's the game plan for that? And then, of course, what happens if, you know, there's an earthquake or a fire in one of the buildings the patient's in, or you're in? Again, uncommon events, but things to think about. I like to say, the more planning we do for these things, 1, the less likely they're going to happen, and 2, the less that they feel like an emergency in the moment. Okay, and then going back to training. So we started with training, we have to almost end with training too. You're gonna have new staff members, or staff members are gonna turn over. New staff members need to learn the workflow, right? You're giving them that recipe, and sometimes you have to help them through the recipe. But knowing, as you're thinking about training, who is going to walk them through it? Are there concrete tasks they need to know before they can actually do this work? Or are we going to hand them this and tell them, run with it? When do they actually need to know these tasks? So are there some things that need to be known day 1? Are there some things that they need to beta test or play with the equipment, and then we need to teach them? And you know, I'm a big believer in creating cheat sheets for your workflow, knowing as you're doing training, it's time to look at those cheat sheets again and make sure the information we're giving is up to date. Again, living, breathing, keep it up to date. All right, then other things about training in general and thinking about workflows. So in summary, workflows can help telehealth clinics run too. They will make the world of medicine and most of, you know, the industrial world work. They can help telehealth clinics run too. You definitely want to build a clinical team to create one. I was pointing out a couple of spaces where that would be important, like including legal, like including anyone who's going to have contact with that workflow. You should document it. You should definitely revise it and improve upon it, like I was pointing out. And when needed, create cheat sheets. So we're going to take a moment, and this is that full workflow again. This is again into another clinic workflow. Here's another example. And we're going to take, here's a third example, and that's another example. We're going to take a moment of what it could be to run through a telehealth visit if you're doing in-home visits. So this is another telehealth script, workflow we created when we're doing telehealth into the home of patients. So obviously we have all this pre-work done. Most of our outpatient referrals come from our outpatient clinics or outpatient providers, and that has not changed. But when we get a new referral now, you'll notice at the top, starting with the blue, someone calls the patient, they open a telephone encounter, and the reason is so we can document that we've reached out to that patient, right? We now have standard phrases that we drop into those notes if we can get a hold of the patient saying, this is what we offered, and we confirmed that the patient has the equipment, has everything there, has a space that's somewhat private, and then set down the things that we need potentially for them to know if we're going to do tele, such as they probably should not be out of the state of Washington when we do tele. And obviously, again, please don't be driving. And then you can see the branch point, right? If a patient can't meet those things, we're going to try and schedule them for an in-person visit whenever is appropriate, or see if there are things we can do to mitigate the circumstances. If they're able, then we're going to review the telehealth script, which is a standard thing we have our staff, support staff trained to review with the patient, just talking about insurance and any of the other things, testing Zoom if they want. And if the patient agrees, we have a formal thing that explains the telehealth thing that includes our attached documents, anything scales that they potentially need. And then it explains to our scheduling staff provider how to actually schedule patients and when patients are arrived. So that's what those next dots are for. So this is all our pre-work, right? Well, what about running through an appointment? What does that potentially look like? So initiating appointments. Depending on how you have things set up, this is very much a moving target, but either someone at a pre-appointment may have sent the patient a Zoom link, or your provider may have sent the patient a Zoom link, but you both have providers, right? You would log into your Zoom account, that's what's over there, and then you'd start the visit using the correct meeting ID for the appointment. And you can see some sidebars we've created for the patients. You admit the patient to the room using the appropriate Zoom aid. You're going to introduce yourself because you have a provider, showing your badge. Again, confirming the patient's identity as best you can, which is date of birth. Do a brief teleconsent. We are asking our patients their exact location and a phone number to contact them at, again, partly because of safety issues, partly because we're doing tele into their home. And then we follow up initially if someone has not submitted electronic versions of a PHQ-9, we do that at the beginning of the appointment. And then we run our normal appointment. Then we get to the after appointment, right? So we've now completed an appointment. And after the visit, we are confirming that the visit is listed as a tele-remote visit type on the Epic schedule. So that just, again, labeling things as they are, making the computer know that we did a telehealth appointment. We're adding any sort of dot phrases if needed to make sure we're documenting that it's a telehealth appointment, or if there's anything odd that went on with it, such as there are rare instances right now with established patients where I had mentioned that ideally a patient would be in Washington State. If you're stuck out of the state, there are maybe some wiggle in there. Again, routinely should not be done, but if you're derivating from that, you need to document it, and you need to document why. Then the provider is dropping an appropriate CPT code with the GT modifier, and then signing the note and sending it to the appropriate people. All right, so that's kind of, again, how you can condense all those steps into a workflow. Running from here to running to appointment to an after visit. With that, I think we'll skip, stop sharing. and I will ask her questions. Let's see. Any
So
questions?
far,
from the discussion?
I was just going to say, so far we haven't had any questions in the question and answer box. I wonder if you want to take a moment to do the poll to kind of check in with people and see where they are with
Sure, we
implementing
can do that.
telehealth. Can we, Christina, can we do that? There we go. As you can see, we've just put up a poll, how long you've been offering telehealth services. Just getting started. Greater than 6 months, 1 to 2 months, 2 to 6 months, or other. And about half the people have voted, so we'll give it another minute or a few seconds anyway. Looks like we've sort of stalled there. So it looks like most of the people on the call, 44%, are just getting started now with telemedicine. The next group, 35%, have been doing this for 1 to 2 months. And then about 9 or 10% have been doing it for greater than 6 months or other. And then just 1% has been doing it for 2 to 6 months. So we'd be interested in hearing from folks. How's it going? And you know, do you have questions about workflow and how to set things up, especially for those of you folks who are just getting started, or those of you who have been doing it for a while, a little bit more seasoned, if you have any insights about setting up your programs and your workflows and any pearls of wisdom. Okay, we have a question. Could I get more information on creating the telehealth script?
I mean, definitely. Are we going to end up posting that, Cara? We established that? I can show it for sure.
Yeah. Yeah, if you want to show it, and I think
Sure.
I think we can probably post again these. We are going to be posting on the website some sample consent forms and some other documents, and just keep in mind that these are examples, and that you should be looking at them for ideas, but creating your own that is a good fit with your clinical setting.
Yeah, the reason I did a lot of open-ended questions, because the reality is some of the decisions and branch points we've made are partly because of our EHR and partly because of what our staff needs. So know that as you're going through and asking those questions, you can definitely look and see how we've problem solved that, but don't feel obligated to do exactly what we're doing, because some of it may not apply to you. For example, if you don't have someone who's, if you don't have an extensive support staff, you may be calling and offering patients and having that discussion yourself. But I will show what we have or what we do for our offers right now. Go ahead and share screen again. Move that over real quick. So these are different scripts that we have, and we've actually created dot phrases so it's faster. Dot phrases are just shorthand that you can put in some EHRs. Depending on your EHR is also possibly a stamp. But this is our standard thing we have all of the staff who reach out for our providers and call our patients talk about. And it gives them ideas of quotes of what to say, such as, our psychiatrist would like to do a telemedicine appointment with you over video. Would you like to learn more about it, right? Do you have a device such as a smartphone, tablet, etc. at home? And then reviewing kind of those key things. If people have questions about what telemedicine is, scroll down real quick so you can look at a little bit more. This is our offer. We have standard dot phrases like telepsych offer, so we can actually document that a patient has agreed. This is an example of how you could potentially create a telehealth appointment information. message you can send to your patient. So before, again, everything's moving so fast with technology, when I was sending my own invites to patients, this is what I would do. I'd include the date and time. I would have my own Zoom link and then an emergency number right here for the clinic. And then we actually had links to all of our care agreements. And then there's a brief telehealth consent example. And then this is our very long explanation of what we're doing at the beginning of an appointment to label it as tele. And what our legal team has been saying that at our minds here have been saying to put in potentially the start of our documents. It seems long, but it actually goes pretty quick.
And we also back up there the message that's sent through eCare for those who are UW patients using eCare. We also send a link to a document that's sort of the patient information form about telemedicine, you know, sort of what is it, how does it work, what are my expectations, what are some of the risks and the benefits, and to explain that the insurance company will be billed, to expect, you know, a copay or deductible, just like you would for an in-person. So we sort of give them an overview on that level, as well as expectations about the space that they will be in, that it'll be in a safe space and that it'll be private, and that, you know, we would ask you to introduce anybody else who's in the room with you, and, you know, sort of the overview information so that they're not coming into it completely blind.
Right. It's a good place to mention, please don't be driving when we're talking.
Yes.
So the reason we have all that written out is, as I said, having some of that documented and not having people to create that in their head over and over and over decreases stress and manages some expectations, but it also make sure you are dotting I's, crossing T's. So I think Kara said that those would be posted, so you can potentially take a look at it.
Yeah. So Jen, we have one comment. I'm looking forward to doing telehealth, however, a little nervous as well. More about making sure I'm covering everything I need to do. Any comments?
Yeah, I would say I relate to this statement strongly, and I think a lot of us do. Everyone's kind of a little nervous. Going through, as I said, some of those things, making sure you're dotting I's, crossing T's with legal, with billing, and with your documentation. All of those things are great. You spend a little time putting the effort forward. And then remember, you're going for good, because you're never going to be perfect. And anytime you're doing a workflow, you can always update it. You can always make those changes. So at some point, you jump. You can do it. I believe in you.
And then there's a question, are you collecting any data for improvement opportunities, including patient and staff experiences?
Excellent question. I don't know if we're doing that globally. Are we, Kara?
Just like most of you, the University of Washington anyway, has been very rapidly implementing telemedicine across the academic medical center. And we admit that it's good, but it's not perfect. And so, yes, we are now that we have a lot of things up and running, we are going back to implement some sort of QI and QA measures and opportunities, because we do want to look and make sure that what we're doing is working well. We want to be preparing for when the public health emergency is over. We all have our fingers crossed that'll be soon. You know, have we set things up the right way? And yes, we have, you know, at least in our psychiatry clinic, we have almost 100% people coming via tele now. When we don't have to be in isolation, is that appropriate? Do all patients need to come in via telemedicine? Are they all appropriate to go in via telemedicine, or is it more to have some people come in person? So I think we'll be thinking through a lot of those things. So that's a very excellent question.
So stay tuned. Also, definitely collect and create your own.
Yes.
Let's see.
Um,
I think there are other questions. If we use a platform for video visits not integrated with Epic, how are folks getting signatures for patients? Especially for like counselor disclosure statements. Has the state altered requirements for counselor disclosure statements? A great question. Some of the things we've done here is we've definitely snail mailed things to people, but I don't know if Cara has any other answers to that, or if other people have experienced that or have other answers.
yeah, I think HCA has guidance that specifies that getting verbal agreements is good enough for now in most cases, but that they do want to follow up and get written, consents on things. And so I would say that in most cases, if you do a verbal agreement and document it, and then send those forms out to the patients, whether you have an electronic means of doing that, or if it goes by snail mail and has to come back to you that way, or you wait until the next in-person appointment. I think that's the guidance that HCA is putting out.
So in COVID world, you're kind of doing that. It may change over time.
Yeah.
One of the great things we're hoping for is e-signature. It's not happening yet. But yeah. Yeah, exactly. Not a question, but I talked to BH organizations that's starting to use DocuSign for things. Yeah, I think we're looking at that at UW too. So as I said, it's going to evolve. I think technology is going to catch up, but for right now, if you can't do it, you can always get a verbal consent and snail mail someone as a backup.
Ben, are you seeing that question about school-based mental health services?
Yes, I actually don't know if I have a great answer for that. So
I
yeah.
was going to say we may have an answer for that. A week from Friday, we will be having, I don't think we announced it yet, but we will be having a presentation by Dr. Bob Hilt, who's at Seattle Children's Hospital, about doing telehealth with children and families. And so we'll pass this question on to him to see if he can address that during his session.
Yeah, so great question. I wish I knew. I just don't work
Right.
with schools or children.
Yeah.
Well, this is Christina again. I just want to be mindful of the time and thank you so much for this discussion. Wanted to go to the next slide just to remind folks how to get in touch with the BHI. So again, these slides will all be sent to our website posting this session, and then we'll have the recording in a day or two, as well as some Q&A. So we'll make sure we grab those from the chat box, as well as the Q&A box from there. So, okay, next slide. Just a reminder, what's really important besides delivering these wonderful trainings with our partners here are getting your feedback. So you will get an email probably tomorrow from Zoom with an eval link, unless you've already clicked on it and grabbing that from the chat box. It literally takes just a few short minutes, but it really helps us evaluate our work and be able to give feedback to the trainers in a confidential fashion. Your name, email, none of that is connected to that. And it really helps us develop future programs. So you'll see something, you do come up with a kind of personal code with some guidance from SAMHSA, just do a few questions and it really helps them know what can happen for the future session. Next slide. And if you want to know more, certainly the BHI has their website, but the Northwest MHTTC, this is just one of many offerings that we support. And so if you want to visit our website, this is how you can do that. You can follow us on social media, you can email us, but you can learn and sign up for our newsletter and get to know about announcements about trainings and resources, not just from our region, but from all across the MHTTC network, as well as other trainings. So if you're interested in that, please feel free to go to our website and sign up for that. And I just want to say thank you again to our presenter and panelists. Really, really appreciate the time and all the diligent answering of the questions. So if there's nothing else, I think we'll wrap up. Is there one
I'll
more?
just point out two more things that came into the Q&A. So I don't know if you can unmute Stephanie Shushan. She's recommending that the Smart Center might have information on school-based services. And I don't know if Stephanie can be unmuted to tell us a little bit more about that or not.
Well, and actually, so the Smart Center is part of our grant as well.
Oh.
There's a school mental health supplement. So if you go to the Northwest MHTTC website, there's actually a couple links directly to the Smart Center partnership that we have with them for school-based stuff. So if there's anything that is provided, I'm pretty sure they might have it covered, but they are certainly available to consult with as well. All right. Well, thank you everybody for attending and taking the time and amidst all of this to learn more about this important topic. Thank you so much.
Thank you.
Thanks,
Thank you, Dr.
Jen. Thanks,
Erickson.
everybody. Yes.